Hi there.
Hi.
I am Lisa Castleberry. I'm a PA student here with Methodist, and I'm here to do a thorax and lung exam. Would you mind confirming who you are with your name and your date of birth?
Mr. Smith, January 1, 2000.
Perfect. That's what I have, so we're on the same page. I'm going to wash my hands before we get started. While I'm doing that, tell me a little bit about your drive over to the office. Did you have any trouble?
Traffic was fine.
Okay, do you live a long way from here?
About 30 minutes.
Okay. All right. So I can tell off the bat that you are alert, that you you know where you are. Where are you at right now?
I'm in a PA school.
Okay. Do you know what day of the week it is?
Monday.
Okay. So you're alert and oriented ×3. You are well groomed, and you do not appear to be in any respiratory distress. You're not struggling to talk. You're not using accessory muscles to breathe, and I don't see any central cyanosis. Okay. I'm going to go ahead and proceed to do your exam. The first thing I'm going to do is just inspect your thorax. I'm looking to make sure that the thorax is symmetric. I'm looking to make sure there's no deformity. Usually I would have the patient take off their, at least their shirt, so that I can inspect the actual surface of the thorax, looking for any trauma or scarring or bruising, and ask about those things. But I'm just going to ask you, do you have any of that?
A little bit on my right shoulder blade.
And what is that from?
A motor vehicle accident.
Okay, did you have surgery?
Yes.
Okay. Any foreign bodies or anything left in your...
Possibly. My wife thinks so.
Well, we'll talk to her later. So anyway, we're going to move on. I'm just going to take a look at my checklist here so I make sure that I don't miss anything for the students. So I've just checked the symmetry for both the front and the back part of the thorax. I also want to look at the peripheral circulation, the nails, as we talked about, looking for any signs of clubbing or cyanosis, which I don't see in this patient. And also, as he's just sitting here breathing, just making sure I'm looking that he's not struggling to breathe, that I see regular rise and fall of the whole thorax and cavity. Okay, so that's the inspection portion of this exam. The next part would then be your palpation. I tell the patient I'm going to start on the back here, and I'm going to press on your chest wall. If you have any tenderness, please let me know. So I would just use the bony prominences, the scapula here, just to press around and see if the patient has any tenderness. And then also the vertebral column, check the spinous processes here all the way down. And then also check the ribs. And actually, I didn't start high enough. We'll check up here. And let me know if you have any tenderness, sir, as we do this exam.
Certainly.
And as you get down past the scapula, I'd kind of flare out here, grab the ribs as you go around, and go on a little bit laterally so that you can get the lateral edge of the thorax. Okay? So he's not endorsing any tenderness there. And then fremitus, we're going to go ahead and do that while we're behind him. And then when I go around to his anterior aspect, we'll repeat the palpation and the fremitus and also chest expansion there. So the next part, we've palpated for tenderness. Now I'm going to look for chest expansion. So again, you want to come down, you want to find roughly the 10th thoracic spinous process. And actually for him, if you'll lean your head forward, the most prominent process here is C7. Okay, if you look back up for me. So there's T1, T2, T3, T4. And just as a side note, class, T4, like I talked about earlier today in lecture, kind of denotes the edge, or the inferior edge of the upper lobe of the lung, and then the apical part of the top of the lower lung field. Okay, but you would just keep going. T5, T6, T7, T8, T9. So T10 is roughly about here. So what you would do is you put your thumb on either side of T10, and you kind of hug the ribs with your fingers, and then using a medial motion, just kind of gently push the skin towards your thumbs in the middle to make a little skin fold, and then ask the patient, take a deep breath in for me, please. Okay, you're looking for a symmetric expansion. Breathe out on both sides. You want to see the thumbs come apart and then come back together as he did there. So that's normal chest expansion on the posterior approach. And then for fremitus, again, we're just checking for, to see if there's any increase in vibration as the patient speaks. So for this, sir, I'm going to have my hands on your back if you'll say 99.
99.
And one last thing, as you move into fremitus as well as your percussion and auscultation, if you could cross your arms over your chest and grab your shoulders for me. Great, that just opens up the scapula and gives you a better approach to the lung fields. So again, sir, 99.
99. 99. 99. 99.
Okay, thank you. You can go ahead and relax your arms. Now for the purpose of this video, I'm going to continue to do all of the palpation right now, both front and back, but when you start practicing this for your OSCE, you may want to go ahead and just do all the elements of the exam on the posterior and then come around and do the anterior. But just so it's clear, I'm going to go ahead and switch to the front and we're going to do the same thing. So I need to assess, again with palpation, I'm going to look for tenderness. So again, I'm going to use the bony landmarks. I'm going to check the clavicles. And again, sir, if you have any tenderness, let me know. The sternal notch, so you have your bearings. The body of the sternum here, down to the xiphoid process. And then again, just walk your way down the ribs. And again, if you have a female patient, you may need to ask her to displace the breasts for you laterally so that you can feel the ribs all the way down about to the level of the 6th rib here, and then come around laterally to kind of catch the 7th through 10th rib. And you may be able to feel the cartilaginous tip of the 11th rib on the side. Okay, so no tenderness there. So then we're going to move into chest expansion on the front. So again, we find his xiphoid process. That kind of is the landmark at the base of the sternum. Again, you would go just laterally to that, and again, kind of hug his ribs with your hands, and then gently press the skin together here, make a little skin fold, and then ask, take a deep breath in for me. You're looking for a symmetric expansion as the thumbs come back. Excellent, thank you. And then finally, for palpation on the front, we're going to do fremitus again, so I need you to also say 99 again. I'm going to listen for or feel for vibration.
99. 99. 99.
Okay, again, if this is a female, have her displace her breast so that you can feel. You don't want to move her breast tissue in an inappropriate or uncomfortable way. Okay, so this is the palpation portion of the exam. So now we're going to move on to your percussion. So again, I always start in the back for percussion and auscultation and move around to the front. So again, sir, if you don't mind, I need you to cross your arms. Thank you. Grab your shoulders. And remember, with percussion, what you're doing is you're assessing for resonance and abnormal resonance, and you want to try to assess the upper posterior upper lobes here, as well as all of the lower lobes, all around to the lateral aspects. So with his arms crossed, that helps get the scapula out of the way. And then you want to use the non-dominant hand, the middle finger, the distal joint here, and I would start up here high so you can get the upper lobe back here, and you want to use the middle finger of your dominant hand, kind of like a hammer, and you want to use the tip of your finger, and it's a motion like this with your wrist, and you can actually hear it. Okay, now make sure your fingernails are cut better than mine, or you'll just scratch the crap out of your finger. So you want to check a couple times in this location, and then do the symmetric location on the bilateral side or the contralateral side here, and then move down. Very important that you compare symmetry. Always compare the opposite side, excuse me. And then again, go ahead over and get a lateral aspect. And be careful not to touch his body with the rest of your fingers or hand, okay, because that'll mess up the vibration that you can hear. So that's the percussion along kind of the middle and kind of flaring out on the posterior and lateral, and we're going to come around to the front. I'm going to do the same thing here. Patient can be relaxed. Again, if you have a male patient, you can percuss kind of more centrally, but if it's a female, you're going to need to stay more medially, again, because of the breast tissue. But you also want to check at least one spot above the clavicle, supraclavicular, to get the apices of the lungs. So again, with your non-dominant middle finger and your dominant middle finger, and compare sides, and then work your way down. Oh, got a tummy bubble there. You can hear the difference in sound. And again, go a little bit lower and lateral. As you come down, make sure you come around a little bit lateral to grab that aspect of the, as the lower lobe is starting to wrap around right there. So that's percussion. And then finally, we're going to do auscultation. So we'll come back around behind the patient and just explain, okay, sir, I'm going to listen to your lung sounds now. Again, if you cross your arms, thank you. And again, when you palpate and auscultate, just steer clear of the scapula. You won't hear the lungs. That will mess up what you're hearing. So you're going to basically, use the, with these new cardiology 3s and 4s, it doesn't really matter which diaphragm you use, just make sure you know which one is on so you actually can hear. And I would not necessarily put real heavy pressure on your diaphragm, just hold it to the skin. Again, this needs to be on skin, not over the clothing. But you would use the same locations that you used for percussion. And again, compare the contralateral side. So sir, I need you to take some deep breaths in and out through your mouth. If you get lightheaded, please let me know. Great, keep going for me. And last one. Okay, so just notice again, you start up high, kind of go more central, and then flare out as you get down and try to grab one of these lateral positions for auscultation. And then you want to come around to the front. We're going to do the same thing. Hanging in there with me, okay? Mm-hmm. Perfect. We're going to keep doing this. If you'll take some more deep breaths again, in and out through the mouth, not the nose. Sometimes the nose can whistle or be congested. It can affect what you hear, I guess, downstream. So again, don't forget about your apical lung borders here. So make sure you listen at least once above the clavicle. Same thing. You may have to use the smaller diaphragm if it's a tight space. Okay, go again. Again, you need to have full contact on the skin to be able to hear properly, okay? All right, we're going to keep going. And just like with percussion, you don't want your hand touching the body. You'd like to keep the rest of your hand off of the chest. You doing okay? I'm going to get one more on each side. And again, make sure at each location you allow the patient to take a breath in and out before you move to the next location. Okay? All right, so that wraps up the majority of the exam, but there will be times when you're suspicious, you hear abnormal breath sound, and you want to try to define what you might be hearing, what could be causing that. And so for that, we have those 3 special tests we talked about in class today. We have egophony, we have bronchophony, so I'm just going to forget that one, and then whispered pectoriloquy. Okay, so if you're asked to do those special tests, egophony, all 3 of these actually you're going to use your stethoscope for, and I personally like to use the back, so that's where I'm going to go, because again, when the patient's speaking, the sound should go forward and away, and you really shouldn't hear a lot back here. So if you're hearing increase in verbalizations, that could be a sign of some consolidation, and may help you narrow down why you hear abnormal lung sounds, for example, like if you had a pneumonia. Okay, so sir, for this part, I'm going to hold my stethoscope, and I need you to continuously say E for me. And if you need to take a break and take some breaths, fine, just keep saying E.
E.
Thank you very much. And that was egophony. Okay, good job. Well, quite a lung volume there. So that's egophony. And you don't really, you want to hear a faint E, but if it changes to an A, that could be a sign of some consolidation. Okay, so for the next part, I'm also going to be listening, but I need you to whisper the word 99. Okay, if you'll, actually, don't whisper it, just say it normally. Bronchophony is just saying 99 normally. Whispered pectoriloquy, I struggled with that in class too. That is 99 as you whisper. Okay, so go ahead and say 99 for me.
99.
And keep going.
99. 99.
And again, you want to listen
99.
to the same spots on both sides
99.
so you can compare what you're hearing.
99.
And go ahead and get that lateral
99.
while you're here.
99.
Okay, and then for the last one, the same thing, I just need you to whisper 99 for me, okay?
99.
Oh, time out. Guess what I'm doing wrong, class? What am I not having the patient do? That's my oops, see? So make sure they cross those arms. Okay, keep going. Whisper 99 for me.
99. 99. 99. 99.
Excellent. I heard absolutely nothing, which is normal, okay? So I just wanted to demonstrate a very general, brief lung exam for you. Use this as a resource. We'll definitely, in class tomorrow, we'll work through an exam for anybody who needs to see it in 3D, I guess. Sometimes these videos you can lose perspective, but I think using the phone and then also the cameras here, we're going to try to give you several different views. But I just wanted you to have a resource to come back and look at to help you prepare for your OSCEs. Okay? So thank you to the patient. Thank you to Dr. Morris, who's videoed me doing this, and I'll see you in class tomorrow.